on preparing a new generation of PBRN leaders, strategies and experiences in training and mentoring. I would like to briefly review the agenda for this webinar. First, I will introduce our presenters. Then, Dr. Jonathan Tobin will give his presentation. After Dr. Tobin's presentation, we will hear from Dr. James Werner, Dr. Carl Tyler, and Dr. Steven Szanski. We will have a question and answer session at the end of the webinar. I will now explain how to submit a question to today's presenters. To submit a question, you may use the GoToWebinar control panel. Type a question under the Questions section and hit Send, as shown in the screenshot on this slide. You may submit a question at any time throughout the presentations. At the end of the presentations, I will read the questions out loud, and our presenters will respond. I am now pleased to introduce today's presenters. Dr. Jonathan Tobin is President and CEO of Clinical Directors Network, a practice-based research network in New York City that is dedicated to improving clinical and population health outcomes for low-income and medically underserved communities by creating community academic partnerships around research, education, and service. Dr. Tobin is a clinical epidemiologist and is co-director for community-engaged research at the Center for Clinical and Translational Science at the Rockefeller University. He is also a professor in the Department of Epidemiology and Population Health at the Albert Einstein College of Medicine of Yeshiva University. Dr. Jim Werner is a researcher and behavioral scientist at the Case Western Reserve University, Department of Family Medicine. He leads the PBRN Shared Resource of the Cleveland Clinical and Translational Science Collaborative and the Case Comprehensive Cancer Center, and is PI of an AHRQ-funded P30 COIN PBRN Center that links PBRNs for collaborative research across Ohio. Dr. Carl Tyler is a clinician researcher in the Medicine Institute of the Cleveland Clinic. After 10 years of private small group family practice, he entered academic medicine, where he teaches family medicine residents and medical students, and conducts practice-based research related to the care of adults with intellectual and other developmental disabilities. Dr. Steven Szanski served for more than 30 years as the Director of Research at the Case Department of Family Medicine and as the methodological and statistical consultant for faculty, research fellows, graduate students, and residents. I will now turn the presentation over to Dr. Jonathan Tobin.
Thank you so much, and I really appreciate the opportunity to share some thoughts and some insights and experiences around developing a new cadre of clinical investigators who work with practice-based research networks. So I'm going to use this opportunity to talk about principles of mentorship as a specific type of partnership, and to think about these kinds of partnerships as strategies for recruiting, retaining, and engaging clinicians in practice-based research. And I'll provide several examples and some lessons learned, and provide also some resources through our P30 training program, which we refer to as the N² PBRN network of networks that's funded by AHRQ. And so to do this, the first thing that I really think is critical is to think about the different categories of mentees. And so I've begun to at least highlight some of the categories, and individuals may fall into multiple categories. But if we think of the framework of comparative effectiveness research, the right treatment for the right patient in the right setting, we can use that to generalize the right approach to mentoring and to building mentor-mentee relationships in the right setting and at the right time. And so I've divided it into the different categories of people that we generally work with at Clinical Directors Network. And that includes practice-based research network staff, investigators, and project directors and managers, CHC or Community Health Center or federally qualified health center practicing clinician investigators, and that often includes more senior people such as clinical directors. The name of our organization derives from that, and also involves junior clinicians at different points in their training. But we also work very closely with academic medical center investigators, including both senior faculty and junior faculty, and then finally students in graduate programs such as Masters of Public Health, doctoral programs, undergraduate medical students, and then clinicians in training, residents and fellows. And so it's really important to think about the different stages stages of careers and the different endpoints of careers in terms of designing an approach to mentoring. So some of the issues that are relevant are really similar across all categories of mentees, and I use language and reflection on language as a way to think about this. So I've had the question put to me often, can you talk about how to use clinics for doing research? And I try to use that as a teaching moment to think about what's the language implicit in words like using clinics for doing research, and try to reframe that into how do we engage and collaborate with practicing clinicians, patients, and organizations. And I think it's worth considering the bidirectionality of research, top-down versus bottom-up, and the so-called mixed model, which really characterizes the work at Clinical Directors Network, as a way of thinking about that mentor-mentee relationship as a form of that kind of bidirectional communications. But the principles that apply to protecting patients also apply in mentor-mentee relationships, and we have to consider the autonomy of the mentee as well as the mentor, and use that opportunity when we think about integrity and respect for patients. And so I like to think about how we should view the common rule as a restatement of the golden rule, which is what you don't like done to you, you should not do unto others. And so I think that applies in the mentor-mentee relationship. But some of the issues are different across the categories of mentees, and I think in terms of developing and enhancing these relationships, it's critical to begin with individualizing that particular set of needs around professional development needs. And so the needs of a practicing clinician may not be the same as an academic investigator. And so oftentimes the criteria for advancement and promotion in a health system are going to be quite different in a community health center than they are in an academic medical center. And so having that in mind and building a program of experience around those specific needs is going to be quite critical to the success of that relationship. And productivity turns out to be a really important measure, but again, it's defined very, very differently. And the metrics of success in an academic setting may have to do with grants and publications, whereas in a community-based practice setting, it has to do with encounters and clinical productivity. So I like to ask the question, what are the service obligations in the workplace, and try to design an experience around that that helps an individual meet their service obligation and build a trajectory to advancement and promotion that is going to work in that setting. But I think we have to ask the question, what does successful translation of research into practice look like in order to really think about that? And so to do that, I have a couple of general principles, and then I'll quickly go through a few examples. So they fall into the 5 R's. Be respectful of time, your time and the time of others, and what you ask for. Be respectful of what you request of patients and participants, of mentors, collaborators, and staff, because everybody's time and effort is scarce and limited and valuable. We need to be resourceful. Research is demanding and resource intensive, and funds are always limited and scarce. I think being reciprocal is a really critical way to think about enhancing these mentor-mentee relationships, and what do we need to give and what do we need to get out of this relationship. And finally, being responsible. What can I do for this relationship? So there are a couple of different examples from our research that I want to highlight because I think they provide different approaches to developing new investigators and to creating mentorship opportunities. And so I'll go through a Train the Trainer project supported by NIH and CDC, some of our on-site research training activities that we are doing with some of our member health centers, and then similarly some of the research training that we're doing through distance learning, and then finally looking at some of the opportunities in our P30 grant and highlight a concrete example of research project participation as a way of building that. So another set of principles that I think are really helpful to examine in thinking about these relationships are stages of community-based participatory research. And an ideal CBPR program engages the community at all of these stages, from selecting the research question, designing the study, recruiting patients, conducting the study, analyzing the data, disseminating the results and implementing the results in broader practice setting. And so I think in designing opportunities to engage practicing clinicians and others in research, it's important to think about engagement of research at each of these opportunities, and I'd like to highlight that with a couple of different examples. So the first project that I'd like to look at looked at behavioral intervention for women with HIV that we implemented with our colleagues at the University of Miami, the Miller School of Medicine, at health centers and practices in Miami, New York City, and in northern New Jersey. And we developed a series of behavioral interventions that we tested in efficacy and effectiveness studies. And then in the most recent one, which I'll quickly mention, we developed a training and dissemination model that provided the opportunity, without taking people away from their clinical practice responsibilities, to become trained in a new model of care delivery, a group intervention using a structured, manualized cognitive behavioral stress management intervention, where we brought a master therapist into the clinical setting, and the therapist we referred to as research leader. And the therapist provided, in the first instance, a set of trainings where they conducted these 16-session behavioral interventions for 8 to 12 HIV-positive women, either in English or in Spanish. And the community health center site staff, after going through some learning and experience in reviewing the manual and the elements of the training, served as the co-facilitator and the co-therapist for 16 sessions. At the end of that, we then reversed roles where the site staff became the therapist and the research staff became the co-therapist and provided direct feedback on the clinical skill development of the therapist that we were training to conduct the work at the sites. Then in the next round of implementation, our therapist was absent, and we turned to the site therapist, the site staff, to provide the training for a new person at their site, who then conducted 16 sessions in the mentee role. And at the end of that 16 weeks, they reversed roles, and we had the person that we, as the researchers, had never directly trained by a person on site, and then that person provided clinical feedback. And I won't go into the results of the study, except to say that we could find no difference in the clinical endpoints that we looked at, HIV viral load and depression, between patients who underwent the therapy from mentees that we trained or from our research level staff. So we take that as proof of the training model and its clinical effectiveness in training new people to carry it out. So we think that's one model. A second model involves bringing together a group of clinicians, and we did this in collaboration with colleagues at the Lutheran Family Health Center Network here in Brooklyn, New York. And we developed a year-long training course to help practicing clinicians develop their research interests and skills. And we developed this day-a-week program, 1 day a month, over the course of a year. So it involved a significant commitment on behalf of the clinical leadership at the Health Center Network, and we provided the curriculum and the mentoring experience to build a set of what were 4 different research projects, where the curriculum was designed around a just-in-time training for the research projects, and it enabled the groups of approximately 4 to 5 clinicians in each research project group to develop and carry out a pilot study that involved design, implementation, epidemiology, biostatistics, human subjects protection, grant writing, and everybody received about 50 CME credits. This is a sample agenda where we brought in an outside expert in clinical informatics and tried to develop the content of that presentation around the needs of the 4 different projects. And I'll mention where these curricula can be identified and viewed online. Projects identified by the practicing clinicians looked at hepatitis C screening, childhood and teen obesity, improving access to contraception to reduce teen pregnancy, and an intervention around improving type 2 diabetes control. So this is an example of an outcome of one of the sessions where we looked at the clinical and the patient-centered outcomes for each of the different groups and developed the training curricula and the experience around those. Third example that I want to quickly mention has to do with our network of networks funded through AHRQ, and we have 2 PBRNs in New York, 2 in Boston, 2 in Chicago, 1 in Oakland, and 1 in Portland participating with us as part of this N-squared PBRN. And our distance learning program has, similar to this webcast, about now 740 courses online and available at cdnetwork.org. And we use these opportunities to both provide live content and to provide simultaneous capture of conferences and workshops so that people can participate at their convenience. And as part of a collaboration with the National Association of Community Health Centers and the Clinical and Translational Science Institute at Children's National and George Washington University, we developed this online research training catalog, which has several dozen courses that we've identified as being relevant to practicing clinicians to give them opportunities to access. So we've worked with different organizations to build curricula out of existing content that's up on the internet. So we view community engagement as a form of clinician engagement and community engagement, and try to use a variety of different interactive real-time tools. And one of them are developing these collaborative learning groups as part of our network of networks. And with our academic partners and our network PBRN partners, we've developed a series of webcasts around best practices in clinical research innovations, and have these 4 different tracks that are not only available to our member networks, but to anybody who's interested in joining, where we look at these innovations in practice-based research and look at different methods that the different PBRNs have implemented in their own studies. But one of the outcomes of this was the identification of the need for a more fundamental curriculum for practicing clinicians in community health centers. And so I've just shared with you 2 of the examples that we've developed. And it also provides an opportunity for our partners to share the results of the PBRN studies that they've conducted. And so just to give you a flavor of some of the programs, we're looking at social determinants, HIV prevention, integrating patient-reported outcomes, and collaborative community-based research. And these are topics that are available from our webcast library. And we found that not only is it important to make these available as one-on-one webcasts that can be viewed at the convenience of a learner, but these can be viewed in groups. So we encourage community health centers to use some of their staff training time to watch these programs together and to discuss this in a group setting. And we find that this is a way of building the local capacity and building collaboration within the health centers. So the last example I'm going to mention very, very briefly is a study around building capacity for surveillance for community-acquired MRSA that is a partnership with the Rockefeller University Center for Clinical and Translational Science and health centers both locally and as part of our network of networks. And for this project, we brought together laboratory investigators, clinical investigators, and practicing clinicians from a wide range of different settings, including those in New York and those who are joining us remotely via our webcasts as well. But our study began in New York City and began by matching hospitals where hospital-acquired MRSA had been characterized to look at the corresponding community-acquired MRSA seen in our local community health centers. And we spent a lot of time building a workflow model to try to design a prospective cohort study that wouldn't interfere with patient care. And so it involved extensive work on behalf of the practicing clinicians to identify opportunities for capturing patient information, including questionnaires, photographs, and clinical specimens. And we expanded this not only to the 6 sites in New York, but to sites in two of our other member networks in Chicago and Texas, and an emerging network in Brooklyn as well. And through this, we've recruited 100 and 29 patients, and our goal is to bring that number to 150. But what's been really important about mentoring clinical investigators and laboratory investigators is finding opportunities for them to do presentations. So this is a presentation by a practicing clinician and a laboratory investigator at a recent translational science conference, another presentation of a nurse practitioner from a health center given at an International Society of Travel Medicine meeting a few months ago, and a project of outreach that became started with one of the nurses in one of the health centers, observing that a high proportion of lesions presented on the head, neck, and scalp, and so she thought to reach out to barbershops, and that brought us to an opportunity of building a collaboration with barbershops and beauticians. The final thing I'd like to mention is that mentoring is reciprocal. So pictured here is somebody that I consider both a mentor and a mentee. Dr. Georgina Zabos was the chair of the board of CDN in its early years and recruited and engaged me in collaborating around research, and Dr. Zabos used every opportunity to both provide care and provide training for dentists in community health center setting. And this lovely photograph indicates some of her mentees. And she came to me with data from one of her practices and asked me to help her look at the data to see whether the sealant program that she was delivering as part of routine care was cost effective. So I recruited a health economist and statistician, and we looked at the data, and the data resulted in this publication. So the multiplier effect that Dr. Georgina Zabos, I think, created as both a clinician and somebody who wanted to be a researcher was use every opportunity to provide care, to provide training, and to provide opportunities to expand access to evidence-based clinical service. So I think there are many opportunities for developing diverse types of careers in clinical and translational research, and everybody has to find their unique pathway, but we have to look at these different opportunities in different settings and try to target and tailor those different kinds of training opportunities to the needs of the settings and the needs of the mentee. And I think it's really clear from this brief summary of experience that practicing clinicians do make great researchers, and we really look for the opportunities of developing new research in situ to provide an alternative viable career option for clinicians who'd like to work in settings such as FQHCs and make research part and parcel of the work that they do in providing access to care to medically underserved communities. So thank you for the opportunity to share some information and experience around training and mentoring, and we look forward to hearing from our colleagues.
Thank you, Dr. Tobin, for that excellent presentation. And we will now turn the presentation over to Dr. Jim Werner.
Yes, it's Dr. Werner. It's a pleasure to be with you today. I'm joined here today by my colleagues Carl Tyler and Stephen Zizanski. Dr. Tyler and Zizanski are going to present with me today. So I'm going to begin our presentation by providing an introduction to training and mentoring and providing a description of training and mentoring programs that we have at CASE, Western Reserve University, that we've had over the past 10 years or so. Dr. Tyler is an experienced researcher now, but has been a mentor or mentee of Dr. Zizanski for many years and has experienced a number of training programs. And so he's going to share from his perspective as a mentee some of the strengths and weaknesses of the different types of programs that he's been in and share some of his experience as a mentee. Dr. Zizanski has been a mentor for more than 30 years at CASE, Western Reserve University, and other places, and a tremendous number of mentees that he has trained. And so he is with us today to provide them the other side of the perspective from that of a very experienced mentor. So I'll go ahead and get started if I can. There we go. So I wanted to just provide a little bit of foundation for mentoring and training. Just very quickly, the concept of mentoring goes back all the way to Homer's Odyssey, and was a figure in the Odyssey who was a trusted advisor and a confidant, an advocate, and a role model, and a wise guide rather than a wise guy. And in academia, it's a relationship, really, of course, where a faculty member is invested in the success and development of the learner. So from the literature, really, it's very similar. It takes place between a person who's perceived to have greater knowledge or wisdom and one who has less of that, would like to gain that. So it's a process for informal transmission of not only knowledge but also social capital, transferring relationships and trust that mentor has gained, and also providing some psychosocial support through the mentoring process. So qualities of a mentor are, Dr. Zazansky may touch on these a little bit more, but the ability to accurately assess the mentee's abilities, to encourage the mentee, to assist them in identifying their target opportunities and goals and where they'd like to go, and setting a course with them on how they can get there. And then finally, feeling some responsibility for their success. And a mentee, on the other hand, is willing to learn from the mentor, of course, so it's a teachable person, receptive to instruction, and willing to accept the strengths and weaknesses of a mentor, knowing that mentors, like anyone else, are not perfect and certainly have weaknesses as well as strengths. So, in primary care, there has been some research done on mentoring. This was a paper published in 2011 of a study they did with 8 highly respected mentors from primary care that were recruited through the Primary Care Research Methods and Statistics Conference. And they participated in a focus group and then 3 rounds of a Delphi process to identify which issues were most important in mentoring junior investigators. And what they found were 5 items that received a perfect rating of agreement. First was the primary task of the mentor is to help the protege identify their goals and then strategize to meet them. So where do they want to go? How can you help them get there as a mentor? And important differences certainly exist between mentoring and collaboration. So mentoring involves relationship, as I mentioned, where the mentor has more knowledge that the mentee would like to gain, whereas collaboration is not necessarily like that. And that may need to be made clear for new mentors and for mentees as well. It's not a guarantee that a relationship will work. They don't always work. And then finally, a mentor who does not care about the protege is not likely to be effective. And I think that's a very interesting one. So we've seen that come up a couple of times now, that there is a relationship that's not only a professional, it is a professional relationship, but it is an investment and really actually caring about the outcome of that other person. So it's a connection that is not only a connection built around information transfer, but also a relationship itself. So I would like to move into telling you now about the training programs that we've had at CASE that have provided time and resources and structure for mentoring PBRN clinicians. So really our programs, really our training programs are the structure and resources for doing mentoring. That's really the approach that we've taken to training. And although we've done a number of different training things over the years, many training programs over the years, just wanted to highlight what's happened since about 2005. We've had 2 consecutive HRSA Title VII funded PBRN methods training fellowship programs. So probably many of the folks on the call are familiar with the Title VII program. This was through the academic administrative units mechanism. These programs, there were 2 consecutive protected 10% time for learners. There were 12-month fellowships, and 18 physicians participated overall. So the first one took place from 2005 to 2008, and it was designed so that 1 faculty fellow at each of the 3 CASE-affiliated residencies was then mentored over the course of a year by an experienced faculty member from our Case Department of Family Medicine Research Division, who is also a practice-based research network investigator. So the fellow identified research areas of interest, went through the process of identifying opportunities in research and designing the research study with the mentor, being mentored in that process. So it was a close engagement on an individual level in focusing and designing and implementing a practice-based research study. It was one-on-one mentoring. There were no formal or group training or educational components in this particular program, so it was an intensive one-on-one mentoring relationship. And we had 3 fellows per year and 9 total trainees, and there was a full-time research assistant devoted to supporting the mentors and mentees in this project. So really on evaluation, what we found from this project was it was a successful project and that the fellows completed their project. But when we look at down the line what the productivity was, we find that they came away with what appears to be limited generalizable knowledge and skills, and there was fairly inconsistent publishing of findings after the fellowship, and modest engagement in research PBRNs as well. So much of this connection, I think, was the mentor doing a great deal of the supporting and assisting and the research assistant implementing studies, but perhaps it was sort of taught but not caught so much by the faculty members who participated. And some of that we tried to address in our next fellowship so we could build more enthusiasm and more commitment and connection to doing research as a group, which is really the design of practice-based research. So this is really, in a way, kind of give a man a fish, feed him for a day, and then we tried in the next one to teach a man to fish and feed him for a lifetime so that it's sustainable and that their skills go forward and that they become active research investigators or participants in research projects through the PBRNs that we have. So our next project was 2008 to 2011, and what we wanted to do with this project was build a culture of inquiry in our department. And these particular grants are limited to the departments of family medicine. So the only folks we could involve were folks that had some connection to the department. And fortunately, most of the people in this area, most of the clinicians in this area, have a clinical appointment here in the department. A great many of them do. So that really allowed our span to be quite broad. So again, we had 3 physician fellows and this time 10-month fellowships. We used the last 2 months of the fellowship period each year to assess and evaluate how things had gone and redesign and improve each year to deliver a much more effective curriculum from year 1 to year 5. And I think that was an effective way to do it. So what we did was somewhat different. We brought people together as a group. So we brought these fellows together, and on the very first day of the fellowship, we actually were working with them to develop an abstract for a project that they were going to do together and submit an abstract and kind of reserve a spot to do a presentation of the research at our statewide Academy, Ohio Academy of Family Physicians meeting. So they were kind of committed and kind of had both feet in deep on the very first day and then began to really design this project and work it out in more detail. So the faculty had already begun working with them prior to the fellowship and had identified some ideas, developed some structure of a study, a framework, but this group project took place first. We wanted to do a group project because it would be an opportunity for them to see the entire research process together pretty rapidly. So in short succession, moving from one stage to the next into the field, into analysis, into interpretation, and so forth. Then each individual fellow in the program also conducted their own research study with support from research mentors, our faculty. We had 4 faculty involved, working with the fellows, but not always as dyads. Working, if say, Dr. Zyzansky's skills were needed, Dr. Zazansky would work with the fellow, and if my skills were needed, I would spend time working with the fellow. So we were really trying to be very responsive to the needs of the fellows. And so we did research training seminars really in response to the needs of those fellows at that given time and where they were in the process of developing and implementing their own projects. We had a senior research assistant work part-time on the grant to support the fellows in some of these more nuts and bolts things of writing IRB applications and revising and resubmitting, and then implementing the projects in the field. And that was actually quite helpful because there was some mentoring that occurred actually even between some of the senior research assistants who have been doing practice-based research for many years and these fellows, these physician fellows. So what we found was we had a high levels of engagement by the fellows. All of the group and most of the individual projects have been published, and good research productivity after the fellowship. The relationships have continued, so we still see these fellows here on a routine basis coming for more collaboration and mentoring with faculty members and with other clinicians working together with them on practice-based research studies. And several of the fellows have received grant funding and have ongoing lines of inquiry in various areas that they're interested in and passionate about. So this enabled them to really connect with what they were interested in and what they want to pursue during the fellowship. Then, fortunately, they've been able to follow through with that. Some of these are just small pilot grants that we've been able to help them obtain, but nevertheless, the momentum is sustained. And we're describing this program and this process in a manuscript that's now under review. So we feel pretty good, and I can't. That was really the design of the fifth year. From the first year to the fifth year, we learned a lot of things and continue to evolve the model. So it's really been an evolutionary process in teaching clinicians from our PBRNs how to do practice-based research and how to develop as investigators, almost towards becoming independent investigators, although I don't know that that's the ambition for any of them in particular, but to be able to pursue questions with their practice-based research network counterparts in other practices and collaborate with academics in the network to do research that is important to them. Another fellowship program that we had from 2005 to 2010 that I just want to touch on briefly was funded by NCI. So this was an R25 research fellowship funded by NCI, and it provided 80% protected time for research training and 20% of the time was for clinical effort. So this was for clinicians. Everyone, I think, was a physician except we had one doctor of nurse, a doctor, nurse practitioner, a DNP. So they had to be clinicians to enter this fellowship because we really believed that it was important to become a practice-based research network investigator and to do cancer control research in PBRNs. It was important to really understand practice. Fellowships were 2 or 3 years in duration, and really the objective of many of the fellows was to, of course, gain knowledge and experience about practice-based research networks, which none of them came in with really any prior knowledge, and published extensively, and then the goal was for many to get an academic career development award, a K award, or an ACS award, or somewhere along those lines. So it was really a traditional fellowship in that there was traditional academic training for those who needed it. Some pursued degrees, others took courses, and then there was very intensive mentoring, so they're matched with a mentor and worked closely with that mentor throughout the program. It was a challenge, however, recruiting fellows from outside of Northeast Ohio, and this was really the biggest difficulty we had in the program. I think we exhausted over 5 years all of the folks who were really interested in doing this kind of work locally, and the program was really designed to bring people in from across the country, and being able to entice people to relocate for 2 or 3 years was a very difficult thing to do. And so what we did in the renewal application was to propose a distance learning program affiliating with cancer centers across the country and CTSAs and having local mentors distributed at the sites where the fellows were. And it was very nearly funded and was on the cusp for quite a long time, but was not able to be refunded. But we learned a lot from this program, and it is a much more intensive program, certainly, than the HRSA programs were, where in the HRSA programs it was really learning by doing and very intensive mentoring with some more informal research seminars where needed. This was certainly to produce independent investigators to do cancer research in PBRNs, and a much more intensive process of preparation. In addition to that, what we have also done is conducted practice-based research network seminar series. We've done this in 2 years now, and it's been very successful. And I really recommend this if you want to build momentum in your research community for practice-based research, to develop a seminar series like this if you can. So in 2006 we had 7 seminars, and this was sponsored by our cancer center, although it was not an expensive endeavor. And in 2009 we did 13 seminars. And so the way this worked was the seminars were held in the evenings twice monthly from 5:30 to 7, so that clinicians and others who have work commitments during the regular workday can participate. We provided a light dinner, something to just tide people over during those hours. And we were able to do this in a building that had free parking. So we found a good place to hold this so that people could pull in, walk into the building, and engage in the seminar and easily get in and out. And so the way we arranged this was it was a 1-hour methods seminar followed by 30 minutes of discussion. And we had PBRN, experienced PBRN academics as well as clinicians present and share research methods as well as experiences of doing research studies, and clinicians shared the results and findings and interpretations of research studies. So this was attended very, we were very pleased with the attendance. Any given night we usually had between 15 to 40 people attending. And these were PBRN clinicians, diverse academics. We had people even from bioengineering and other parts of the university, the social work school, nursing school, graduate students, and then, of course, our PBRN fellows. This was going on at the same time as the NCI fellowship that I just shared with you. And this stimulated so many new linkages and connections between research investigators for our networks. It was really very fruitful. Some of the partnerships were very unlikely, things that would have never happened probably otherwise. So this was not only productive, but it was a lot of fun and a great way to increase the visibility of our practice-based research networks in the area. So this is a schedule, just a sample of some of the seminars that were offered. And so what we did each year, we were able to bring in someone who had name recognition. So in the first seminar, it was usually the kickoff seminar, was by, in this case, Paul Nutting, presented Introduction to Practice-Based Research Networks, and Dr. Nutting is a longtime PBRN investigator and leader who's widely published. And then from then on, it was really those of us who work in the department who are involved in practice-based research and practice-based research network directors. The network directors presented and some of the studies that they did and their results. So we went through various topics, how to a basic theory about practice-based research, multi-method design. Dr. Zyvansky trained in basic statistics, talked about nested data and sampling issues and measurement, and quantitative research, quantitative data analysis, just as an example. Went all the way then to participatory research approaches in the community. We had someone from the IRB come and present about IRB issues, quality improvement, and then cancer control research and obtaining funding for research. So it was an interesting and fruitful experience, and I think it's time for us to do this again. What we did was we captured these seminars the audio of these seminars and the PowerPoints, and then sync them together and put them online as podcasts. A really very easy thing to do. And so these have been online for several years, and I just checked last night. We get somewhere in the neighborhood of about 100 unique visitors per month to these podcasts even now, and that's excluding any bots or any automated search engines that might be searching the sites. So it still gets good hits, and it's from really around the world. Very interesting. Finally, then, we held a course, a graduate-level course, Principles of Practice-Based Research Networks, through our MPH program in our Department of Epidemiology and Biostatistics at Case. And this course, Kurt Stagge and I developed together, and we co-led the course. Very similar in many ways to what you saw in the PBRN seminar series. So the seminar series really laid the groundwork for the course, but the course was a 3-credit-hour graduate course with assignments and much more engagement on the part of the learners. They had to be much more engaged, certainly, to be able to do the work in the course. So this was a good experience, and again, we're planning to offer this again next fall. So there's not always kind of enough people probably every year who will want to take this course locally, but it can certainly fill a need over a period of time. So we're going to offer it again. In addition to that, we mentor PBRN directors and clinicians and investigators through our bottom-up studies, through the studies that we do a great many bottom-up studies, as many as we do the top-down studies, and so we try to maintain some balance there. And the way we've been able to fund this is through our CTSA and through our P30, providing a micro grants of $2,500 to $5,000 to our PBRN members and to our First Fellows. And these micro grants will cover research supplies or research assistant time for doing some kind of a bottom-up study, and we have incentives for doing studies in which multiple PBRN clinicians are collaborating together, and if they're collaborating with the community, more points, and also for collaborating with academics. We want to create these connections between the network clinicians who work as full-time clinicians, participate in PBRN research, and the academics who have the expertise to provide mentoring. Okay, so I'm going to turn it over at this time to my colleague, Dr. Carl Tyler.
Thank you for the opportunity to speak. This is actually has been a welcome opportunity to reflect with gratitude on the excellent mentorship I've received over now going close to 2 decades. And I think it just speaks to the concept that mentorship, in my experience, is a very long-term proposition. What kind of mentorship you need over time differs, and it's a structure that's gradually built upon. And so in a way, this is kind of a case study of what the mentee's experience can be like. So just as a background introduction, I've been full-time faculty with Fairview Hospital, Cleveland Clinic Family Medicine Residency since 1995. But prior to that, I was in private small group practice in a semi-rural county in Ohio. And during my time in private practice, I started to work a great deal with people who at that time were newly deinstitutionalized from developmental centers with intellectual and developmental disabilities, and found that there was very little written about their health and healthcare needs, and a real deficit in knowledge and clinical experience and published work. And so that became the fire in my belly, and that's what kind of launched me to a career in academics. my research training and experience has been, as you see, gradually evolved over time, and kind of references some of the comments Dr. Tobin made early on relating to the different types of training experiences and the ones offered at the case as described by Dr. Werner. So my first training experience was a distance fellowship, which was primarily a weekend experience, several weekends in the course of 9 months, in which, again, as described by other programs, involved each mentee developing their own research project and presenting it at the end of the year, and then some kind of core curriculum, and then some individual work. In that experience, it was with Dr. Clara Bourget. That kind of got my interest enough to decide, yes, I'd like a career in academic medicine, and then that brought me to look for academic positions that would include a fellowship, and so that led me to go to Fairview Hospital and enroll in a fellowship in family medicine at Case Western Reserve, and that's where I met my mentee, Dr. Steven Zazansky. And this is a traditional kind of research fellowship, multi-year. I did it even slower just because of faculty balance and time necessity. And it included a master's degree in a Master's of Science, very similar curriculum to MPH and other research programs. The next kind of research training opportunity was by virtue of a grant, Title VII grant, HRSA grant, that was written by then the Chair of Family Medicine, Dr. Vance Brown, and it was available to us as Cleveland Clinic Lerner College of Medicine was newly formed, and there was a new clinical department of family medicine, and under this Title VII grant, a cadre of full-time family physicians were trained as research facilitators at the family health centers that comprise the Cleveland Clinic Health System. And my mentors at that time were, again, Dr. Zazansky and Dr. Werner. And then I kind of had somewhat of a mixed role of being a mentee, but also involved with some of the teaching and kind of a bridge clinician researcher. And we taught the clinicians about research methods and design as they particularly related to the questions that the clinicians had and what they wanted to investigate. So it was very targeted, very focused type of training directly related to their interest. And then the last training experience was the R25 Fellowship in Practice-Based Research in Cancer Control that Dr. Werner talked about just a bit ago. So when you're working with mentees, some things to consider are the context in which they're looking at applying for and involved in whatever learning experience you're offering. And so I divided each of my experiences into domains of what were my motivations at the time, how did the opportunity fit in the broader scheme of my career and my personal and overall life, how did the timing fit, and what was the process by which the training occurred. So just giving you some examples of how I took those 4 domains and how they applied to each of the stages of my training. Dr. Werner talked about the PBRN seminar series, so I'm not going to review that. But other components that I think were very critical to what I saw as the success of that experience included access to other graduate level courses. So I went to seminars, for example, on health disparities research with my interest in developmental disability and disparities. Seminars that were also offered to other R25 fellows. I think one of the things that are very hard to cram into a course or cram into a very tight schedule is the opportunity to just hear other researchers and what their work is at different levels of design and implementation, being exposed to diverse designs and methodologies, which really are what you need to hear and be exposed to in order to expand your own repertoire as a clinician investigator. Those are often experiences that can't be planned necessarily. You just need to be at the right place at the right time. You need to be embedded within a research community. You have to have time and flexibility to attend those opportunities. But I think that was a critical piece of my development through the R25 PBRN fellowship. Another very smart idea for structuring training and experiences for mentees is to have embedded funding for pilot projects, so that it's frankly the entree card to to the dance, as it were, to help mentees engage in conversation with more experienced researchers who have more resources, who then are more interested in talking with you if you have something to bring to the table. And then the weekly meetings with my mentors, Dr. Kurt Stange and Dr. Werner, and the other fellows. So I think one of the most important things that a mentee can learn is through listening and the conversations that fellow mentees have with their mentors, particularly as they're talking through their research questions and as they're developing their research designs and as they're implementing their studies and engaging in the entire research process. So, you know, again, with each experience, you know, what I learned varied, and with the practice-based research fellowship, I gained, first of all, core content knowledge about practice-based research. You know, my prior work had been more general, quantitative, particularly research design and methodology. Also, the thing that mentees can't get very well from a self-study or other non-interactive type of learning method is pragmatic knowledge about the area of interest, training a PBRN. Again, hugely important mentee experience is being exposed to diverse study designs and methods, having the opportunity to meet and negotiate and work with many different types of research partners. And with my line of inquiry, it's the opportunity of working with other people within the disabilities community, and as Dr. Tobin was saying, you know, engaging and collaborating with them. And I think, again, sequential experiences in research training allow clinician investigators to do that quantum leap from shoestring research to funded research involving much more complex study designs. bottom line, it takes a lot of commitment. It takes a lot of longitudinal work. So the things that I found that were particularly effective in the mentored learning within the R25 PBRN Fellowship were, number one, interestingly, going back to basics, the fundamentals of how do you formulate a solid research question with clear aims, good design and methods. And again, I think as a learner, you can't hear that enough. You can't hear enough how people formulate and revise and refine their questions and their study designs. Learning new things and then having exercises where you immediately apply them, of course, is helpful, and that's just part of adult learning, and that applies to research methods. Again, I've talked about being exposed to novel and creative research methods and design. And then small group discussions. Again, these things you have to have the opportunity. They can't be forced, and to a great extent they can't be orchestrated. They just happen with sufficient opportunity. So, again, my work has evolved in part through opportunities that I had because of the R25, and now I'm working with health services researchers who have expertise in state Medicaid data, researchers who are experts in informatics and EHR-based data analyses. Again, the R25 gave me opportunity to deepen and enhance developing partnerships with the disabilities community and clinicians and researchers who are interested in them. And then also I've had the opportunity with the guidance to successfully complete a competitive 3-year training grant, and it was just kind of perfect timing with the R25. So, Dr. Tobin talked about, expectations of mentees. Again, I think it's highly dependent upon who your mentee is, where they are in their own personal learning and training experience. But these are just activities I was able to accomplish during the R25. And then just, again, reflections about the fellowship. There is in educating mentees a need for core information, and I think the PBRN seminar provided that. And I think sometimes, especially in medical education, there's somewhat resistance to the highly intensive content knowledge that we need to learn, and the same thing applies to learning research. But again, I want to emphasize how important that immersion in the research community is, interaction with other fellows who are also mentees, having that protected time to respond to academic opportunities as they kind of fall on your lap, as it were, which are often unpredictable, but extremely rich if you can make use of them. I talked about the pilot funding for mentees to do work, and again, what helps mentees immensely is being around the culture of other researchers, hearing how they think, hearing how they problem solve, listening to their projects and how they design them and how they evolve over time. So final comments. Training clinician researchers takes a lot of effort. It's a very long-term effort, in my experience. I think if trainees have fire in the belly, they have passion, they have a focus, it's much easier to learn and apply new concepts efficiently because the mentee has has a structure for direct application, and I think personally that's what helped me really learn what I did in the sequence that was available to me, and I think I was able to really inculcate a lot of the ideas and concepts that Dr. Zazansky, as my mentor, provided me, because I had a framework to hang those ideas onto and to reflect about them. I've mentioned again repeatedly about the intangible benefits of being exposed to an academic research community and the importance of protected funding for pilot projects. So thank you for the opportunity to reflect on some of the great mentorship that Dr. Zazansky and Stanley and Werner have provided me. And I'll turn the mic over to Dr. Zazansky.
Thank you, Carl. It's certainly a pleasure to be part of this program on mentoring this afternoon. And I'd like to close our session this afternoon by addressing the question, why even have a mentor? What do mentors provide? And as I went over the 30 years of experience I've had in mentoring graduate students, residents, junior faculty, fellows, I've come up with 7 points that I think apply to just about all fellows. And I'd like to share those and close the program and then open it up for questions. What do mentors provide? First of all, mentors tend to share their research experience with their proteges. That's important. It's a way of getting to be on the same page. Is an indication that we've gone through what you're going through prior. It eliminates a lot of trial and error. The mentor becomes the go-to person. As you're learning, you come across a lot of issues that the mentor can absolutely just provide answers for. And you know what kind of research experiences they've had, so you can connect with those as well. So mentors provide at least part of the shared experience of what their research experience was. Secondly, and this occurs over and over again, and that is the research mentors help you narrow your focus in the form of a research question. It's been my experience that junior researchers have a hard time doing that, focusing their research into more specific research questions. They tend to be much more broad in scope, much more difficult to focus, and the mentor will help do that. The mentor will through questioning, help narrow that focus, and it makes the methods flow more easily. It makes the feasibility of the project more likely, and so narrowing the focus is an important function of the mentor. Third, it's a socialization aspect of mentoring. Mentors tend to introduce the mentee to other research faculty and to the sort of culture of research. When I came to Cleveland, I came from a department of epidemiology. I didn't really have any background knowledge of primary care or family medicine. And my mentor, Dr. Jack Medali, who is the chair here at this time, made sure that he introduced me to other researchers in the institution, took me to state meetings, introduced me to people who were doing research at other institutions in Ohio, and then we repeated this at national meetings like NABCRAC and STFM and so on. Within 2 years, I felt like I was absolutely up to speed and being able to contribute and plan primary care research, partly because of this socialization to what was going on. And it gave me an immediate network of colleagues that I could call on the phone and now email and get other information. So that's an important part of what mentors do. In an academic environment, mentors are often important in doing promotion counseling. If you are in a tenure track, or if you are just a faculty member, who do you go to help you structure your CV? What are the criteria for promotion? Dr. Tobin mentioned some of those in his introduction. What are the criteria for success? Mentors have gone through this process. They know what it takes. They are really good at counseling for promotion. How many publications do you need, et cetera. And that's an important process of what the mentors bring to the relationship. Close on the heels of that, mentors are available not only during the fellowship period, but especially afterwards in terms of helping the mentees prepare their research results for presentation, writing for publication, and writing grant applications to get funding for the future. Dr. Werner mentioned the success of the last fellowship projects we had, where the graduates are more likely to compete for funding. The mentor is always there. Again, it's a go-to person that if you're interested in following up your project with a second project and you'd like to get some funds for that, how do you go about doing that? What are the ins and outs of that? What are the institutional forms? What are the IRB forms? And so the mentor can be enormously helpful in navigating those kinds of things. The next point is it's okay to have multiple mentors. I mean, it is a little unrealistic to expect one mentor to sort of know it all. And I would encourage multiple mentors depending on the content area. You might have a methodological, statistical mentor. You might have a content area mentor. And these all contribute in different ways, but you get the benefits of their experience. So having more than one is a good idea. And the last point that I'd like to make is that as you saw with Dr. Werner's presentation, the first couple of fellowships were less successful in the post-fellowship period. During the fellowship, they did fine. They did their projects. They were able to present them. But continuing to do research, joining PBRNs, was less likely in our first two groups of fellows. And I think part of that is tied to the smaller time frame that the latter fellowships. They were either 1 year or 10-month fellowships, and it's a little difficult to establish this research culture when so much busy work is going on. So my point here is that it is probably a good idea to do more than one fellowship. The second one is the one that really kind of reinforces things that you were first exposed to in the first one. And as you saw from Dr. Tyler's presentation, he's participated in several. And the research skills and confidence to go on, do his own research, become an independent investigator, I think clearly shows through that. So two-year fellowships are more and more difficult to come by, but 1 year or 10-month fellowships are not so much. And doing more than one, I think, in maybe different areas really reinforces the experience and prepares one to become more of not so much an independent investigator, but enables you to use the resources that are available at your institution and to be able to work with your research mentor in a more, the second one goes more quickly, you understand what's involved, and it can be a little bit more in depth. So those are 7 kind of general things that I think a mentor brings to the relationships. And I'd like to close, and then we'll open it for questions with a comment, and that is, on one of Dr. Werner's slides, he referred to a research paper by David Catterdahl. And I would encourage everyone to print that article out and keep that in the folder on mentoring. That, as I read that article, so many things of my research experience I saw reflected in those comments. It's really rich in detail, and it goes through, Dr. Werner just shared with you the 5 comments where all of the research mentors agreed upon. But there are dozens of comments where 4 out of the 5 agreed upon, and many of those are really part and parcel of the mentor-mentee relationship. And it's well worth reading, good thing to have in your portfolio, and a number of those points make good slides. So at this point, I think we'd like to close our section, and I'll turn it over to Dr. Werner, and we'll move to the questions and answers.
Great. Okay. Thank you so much to all of our presenters. So our first question today is, what do you think it takes to build a, quote, culture of inquiry, unquote, outside of academic medicine, for example, in private practice? And what about building such a culture outside of the physician community, for example, among nursing or therapy professionals?
Well, this is Dr. Zajansky. The last fellowship that we conducted here at Case Western was almost exclusively with practicing physicians in the community. And what does it take to do that? Time is always a problem, and to be reimbursed for time away from the office is a significant issue. This would be very difficult to have these, let's say, in the evening, where you had a full clinical day and then you have to come in the evening, and it's additional time out of yours. So I think there are fellowships that are aimed at practicing clinicians in the community, and we just did one of these a few years ago. All of the projects were chosen by the clinicians. They were often things that they saw in their practice that they wanted to examine in more detail, and they came together with us once a week for a couple of hours, and we walked them through the process, some formal and not. But it helped them to gain the confidence to look at their practice, and many of them have continued on to look at other issues. So I think it's partly a time and reimbursement for time issue to bring the clinicians into an academic environment to participate.
You know, I'll just add to that, as far as creating a culture of inquiry in an organization. I think that these kinds of experiences are the foundation of being able to do that, to be able to enable clinicians or members of whatever organization it is to directly participate in the process of learning research and implementing that research, and having some kind of a meaningful and fairly intensive experience, even for a short period of time, so that it becomes part of them rather than just something they once read or heard about secondhand. So if it can become something that becomes part of their, what we were really shooting for is for it to become part of who they were as a clinician and part of their professional identity. In doing what we did, a lot of things with reflective practice, for example, to teach clinicians to look for opportunities for research every day as they practice, to keep a notebook in their pocket, and they needed to come in with that notebook every time we met and share their reflections on practice and research opportunities. That's an example of trying to change culture from just being simply a good clinical care to clinical care with inquiry built in, kind of baked into that. So those are the things that we did.
So I'll add 2 points to this. I think the dissemination and implementation of electronic health records provides an opportunity for some disciplined quantitative curiosity. And so I think building on that so that these are not idle speculations, but rather an opportunity to formulate a precise question, test it as a hypothesis, have either the ability to do the querying and the tabulation yourself if you've gone through some of the kinds of phenomenal training that we've heard described from Case Western, or to be part of a relationship with collaborating investigators that can help with data extraction and some of the tabulation, so that it really provides that framework for people outside of formal academic or research settings to actively participate. I like the idea of carrying a notebook and forcing one to be systematic about those observations. I think we also have to be creative about technology and about time, and to create asynchronous distributed electronic social networks that provide the support and provide the access points that don't have to be simultaneous but can really be done at people's convenience. And I think, again, there are some technological solutions, but again, they rely on people's active participation, feedback, and social support.
Great, thank you. Our next question was asking if we could share the citation for the article that Dr. Zazianski mentioned at the very end that he would recommend that everyone read. I think it was Katrindal. Is that correct?
Yes, that's at the bottom of one of my slides, Dr. Werner, but I would be happy to send to you a PDF of the article. I don't know about the legalities of copyright, but I can share it. I can certainly have a copy of that article and can share it with you.
Great, and we'll also send out a copy of the slides to all of today's attendees so you can see the full citation in Dr. Werner's slides. So those are all the questions that we've gotten. So we will conclude today's webinar. Thank you so much to our presenters, and thanks to all our attendees. This slide lists our upcoming PBRN webinars. Please visit the PBRN website at pbrn.arc.gov for more information on PBRN webinars and events. And please email us at any time with suggestions for additional webinar topics. As you can see here, our email address is pbrn@abtassoc.com. Thank you again, and this concludes today's webinar.
Thank you for organizing this for us.
You're welcome.
Yes, thank you very much. Thank you very much.
Thank you. Thank you, guys.
Went smoothly.